Carry on. I'm
Right,
interrupting.
right,
Sorry.
we'll kick off, we'll kick off. Okay, so hello and a very warm welcome to this Noi Group clinical discussion. My name is Joanna Taylor and I am Director of Noi Group Europe, and I am joined this afternoon by Noi Group teacher and my very good friend Laura Rathbone. So welcome back, Laura.
Hello.
For those who missed our last session, Laura is a respected pain specialist clinician and mentor to healthcare professionals worldwide. She brings a unique perspective, combining cutting edge science with compassionate, inclusive practice. So it's great to have you back, Laura. Could you just remind everybody a little bit about what you are currently doing work wise, please?
Yeah,
And don't forget to mention Pain Geeks.
I won't. I won't. So I am currently in Amsterdam in the Netherlands. I made the move over from being a specialist in London in the UK about 9 years ago now. And I work psychologically informed by acceptance and commitment therapy and trauma informed with a group of complex and chronic pain patients in collaboration with a hospital here in Amsterdam called the OLVG. I work embedded in the pain team, which in the Netherlands means I work alongside the anaesthetists and the anaesthetist team.
Mm.
Um, it doesn't necessarily mean I'm working multidisciplinary as it might do in the UK. So we're building these structures as we go and developing them, which is quite exciting. In addition to this, I am an activist for social justice in pain care, especially queer inclusive care, and have done some work in the UK on that. And together with my friend Christine Petridis, I run Pain Geeks. Pain Geeks is an international and multidisciplinary reading community for clinicians, therapists, and researchers who are wanting to deepen their knowledge on pain and sharpen their academic reading skills. And I just love it because it's a fantastic place to meet people and to share things, and you feel. I guess I've always kind of felt a little bit isolated in my role sometimes, and this is a way of trying to connect us, and it sort of shares the burden of trying to stay updated, right? Because do
Mm.
you know that there are about 4,000 articles on pain released every month?
Wow, I
And
didn't know that.
yeah, and that's not even like a lot compared
Yeah,
to, right? So, but like, because we know that pain is underfunded, pain research is underfunded, there's just not enough. So Pain Geeks is a way of helping people figure out how to get a broad scope of the evidence and how to integrate that into their practice so they can get more bang for the buck when they do read a paper. Because you're never going to read it all because there's
yeah,
4,000 every month. You can't do that. So when you do read a paper, let's make sure that first of all it's worth your time, and secondly you can integrate it well. So I've popped the link into the chat for Pain Geeks. So go and have a look at that, and we have a free area that you can come in and taste and before you decide to take a subscription. So head on over there. That's what I do.
fantastic. Thanks, Laura. And I think that speaks for itself, really, just the amount of reading and interest that Laura has in this subject, which filters down into absolutely everything that she does
Yeah.
clinically and in her mentoring. So, without further ado, we'll crack on with today's content. These sessions are all about giving you a taste of Explain Pain and how to practically use it in the clinic. Some of you will have already done an Explain Pain course, and for those of you, the idea is that these sessions will reinforce what you've already covered. But for anybody that's new to Explain Pain or new to Noi, then these sessions will give you a taste of what is covered in our core course. So Laura has got two courses coming up in the autumn, one online starting the 6th of October and a face-to-face course in Dublin. And for anyone who's interested in attending those, we'll be giving you a little bit more details about those at the end of this. So just hang around at the end and we'll be talking about those. So Laura's going to be talking for about 20-25 minutes. If you have any questions, please pop them in either the Q&A or the chat. We'll monitor those. And if you want to watch the recording of the session, you can access it in the clinical discussion group. The link to that is at the top of the chat. Go and check that out. And you'll find about 30 to 40 other sessions in there about on a whole range of subjects to do with Explain Pain. So today we're going to be talking about pain education and practical communication and education techniques. So Laura, quickly, could you tell us what you're planning to cover?
Oh, I've scrolled away now. Yeah, so I think today we're going to look a little bit at about why you might be feeling like your attempts at pain education fail with patients, and the three elements that I try to hold in my focus when using education as a transformational therapeutic process. Um, then I think we'll also have, if we, take a look at sort of noticing when the other person in the room isn't connecting with you or the approach, and how to work with that rather than get sort of panicked with it. And then we're going to explore this idea of using the story to shift how a person is experiencing the world. So moving into a more empowered place with their pain and their pain experience, and how pain science education can be a part of that process, a really empowering part of that process. So that's what we're going to try and look at
Excellent, thank
briefly.
you. Yeah, we'll try. Yeah, there's a lot to cram in. There always is. So we try and keep it concise as we can, and answer as many questions as we can.
Yeah.
So let's start with the reality that many clinicians face. Why do you think that a lot of pain education attempts fail to create lasting change?
Yeah, okay. So I'm going to be very open and honest about this. Like when I first started trying to integrate pain education into my therapeutic process, I sucked at it. Like I just found myself almost like trying to like force feed information to the patient. And I think what took a while to reflect on was that it's because I was giving information rather than promoting a cognitive and behavioral change, right? So we have to remember that if giving information alone was enough to change behavior, everybody would have stopped smoking immediately, right? But that didn't happen. What had to happen was real systemic change within the policy. We had to do a lot of behavioral change work in order to reduce the amounts of smoking, because information isn't enough.
Mm,
So when we're thinking about sharing something interesting about what we've learned in the research around pain, I think sometimes a tendency for us to try and give facts rather than try and like use the facts to create a meaningful story that helps change happen.
mm,
And I think that's what I learned from Dave Butler and, going to see Lorimer and then being in the wider Noi team, from people like Tim and people like Bart and like, my conversations with like other mentors outside of Noi, like Mick Thacker especially, has had a huge impact on how I've worked. And, um, also like the psychology research around how do we support behavior change that lasts over time. And it's not just giving information. So it's being able to use the facts, the science to
mm,
underpin how we develop a story. That's, I think, one of the things that we struggle with the most.
mm.
Um, and then I think there is also a kind of avoidance sometimes within us as clinicians, and this is not a criticism, this is more an observation. Um, that when the other person is not really in a state of emotional readiness for what we're
Yeah.
doing, um, we can see it, we can pick up on it, we can feel it, but we don't necessarily know what to do with it. And so sometimes we can keep going. I know that's what I did in the beginning. I was like, but if you just know what this is, if you just understand this, it'll be better. But actually, there are different ways that we can work with that. And that's definitely where I think I've benefited from understanding things like acceptance and commitment therapy, having a good
Mm,
psychotherapy framework to underpin that what is necessary to create lasting change.
mm,
Um, and again, maybe just starting too quickly. So when you don't have a therapeutic relationship, challenging someone's beliefs about their own experience, if you don't have a very good relationship or a bond, it can feel like being gaslit. It can feel like someone is denying that person's experience because you haven't worked on the connection enough for you to start undermining somebody's strongly held belief about how they are experiencing the world and the distress that they're experiencing the world in. So these are the things that I think we sometimes get tripped up on.
yeah. I think that what you said is absolutely it's very pertinent because actually these are some of the major shifts that we've seen with explain pain and its perception out in the world,
Mhm.
which is maybe the young Laura, which
Mm.
is this idea of just delivering pain
Yeah.
science to patients. But actually, now where we are with explained pain, which is much more where what you're talking about,
Mm.
which is that it's about a transformation process rather than just getting the information across to the patient. So that fits
Right.
exactly with the evolution of
Yeah.
explain pain as an approach.
And that mirrors our evidence as well, just to say
Yeah.
that, when Explain Pain first came out, we really did think it was about the content. It was about giving people information about how their biology works. And I think there's still a lot of truth behind that. People understanding that pain isn't necessarily associated with damage or injury. You are potentially, depending upon your diagnosis, safe to move. That's a really
Mm-hmm.
important, these are really important concepts to come across. But what we're also seeing in CBT evidence and research and development is that we're moving away from content to process. So what is the process of change and how do we facilitate that rather than this sort of like scripted CBT sort of 6-week programs, which is what we've been using for a very long time, and they do help lots of people, but they don't help everyone. And so
Mm.
how do we focus on having the process flexibly held so we can co-create messages around
Mm.
those principles? Yeah.
Cool. So that sort of takes us really nicely into
Mm-hmm.
the next question, which is about the elements that make pain education transformational.
Mm-hmm.
Could you walk us through these different elements, and if you can, give us some practical examples because they're always really useful to help people understand what we're talking about.
Yeah, so I mean, I think what I'm looking for when I want to when I'm working with a person, I don't have an idea as to exactly what we're going to do over time. We just have a kind of a goal, and then I'm working from these principles of sort of change that I use acceptance and commitment therapy a lot to inform. So I think one of the first things I'm looking for with patients is a willingness. Is this person
Mm.
open to changing their beliefs about their pain? In one way, if I'm wanting to use pain education, is this something that they even understand as being useful to them? Is it meaningful to them? Do they want to invest their time and attention? If you're working with someone with chronic pain, time and attention is not an infinite thing. It's costly, and they're always having to make choices about how they invest that. So it may well be that you're just not in a place where this person is willing to invest that time and attention in
Mm.
this area. Great, do something else with them. There's lots of other options. It's not like exploring pain and the science of pain is the only way of bringing about change. But I'm looking for that willingness mindset. And so you're looking for them to be showing things like curiosity or questioning or not necessarily pushing away as soon as you introduce the idea. So that's one thing that I'm looking for straight away, and I think that's where we sort of need to understand consent a bit more. A bit more, we're not only consenting to physical touch, we're also consenting to everything we do in that room. And it needs to be enthusiastic. Somebody needs to be on
Mm.
board. Um, the next element that I think is really important in bringing about that transformational change is that collaborative, co-created story building or meaning making that I've talked about. Like human beings, when we look at the philosophy of consciousness and we look at how we build up subjective experiences and identity and how we are in the world, we're always trying to make sense of what we're experiencing. Um, and so I think if we can explore that with the person in front of us and try to build a story that works for that person, not necessarily something I want for them, but something that works for them, we're going to get much more movement there.
Mm. Mm.
And that is that second thing, right? Everything that we do in the clinic needs to integrate meaningfully into this person's life. So, when we're thinking about goal setting, we want to be, or I'm looking to, and this is just how I do it, but I'm looking to embed that new meaning into a part of their life that makes sense. So if we're wanting to explore that movement, sometimes movement is contextual, that pain can be contextual, then we might play with context in the therapy sessions and see, how does this shift, how does this change, and then ask them to observe how their pain shifts between context in their environment might give them some activities to do. But I'm bringing it back to this idea that pain is contextual. It's not
Is there an
a,
example of that, Laura, that you could just like when you're talking about contextual pain? Because that's not
yeah,
something I'm always that clear
yeah.
on.
So I think in the sort of protectometer, you call it things like DIMS and SIMS. So it's
Yes.
like we're looking for places, people, and moments in life where you notice pain is worse and where you notice pain might be less. And this can be a really powerful observation that's hard to observe when you're in the chaos of just living with pain. It can be, we might have to very slowly ask people to start noticing, how does your pain feel the day before you're going to a doctor's appointment? How does your pain feel after you've been with your 7-year-old niece? Like
Mm,
these kind of things can be helpful observational moments where people can hear the idea that pain isn't just a fixed sensory feedback mechanism about the state of your tissues. It's telling you something about how you are in the world. So noticing your pain throughout how you move through the world can be a useful moment. Yeah,
mm,
that's what I
cool.
mean. Does that make
Yeah.
sense?
Yeah, it does make sense. Yeah, completely. Tying it back into the dims and sims, that yeah, that brought
Yeah.
it back for me. Thank you. Um, okay, so just moving on here. What sort of techniques do you have for reading the room when you're with a patient? What are the signs to you that help you to understand whether your approach is landing or not with that individual in front of you?
Right. I'm going to be honest, like this is not a skill. This is not just a thing you can be told to do, right? Last time we talked about being brave. I think this particular area requires enormous bravery as a clinician because you've got to authentically observe when this other person is just not connecting with what you're saying or is getting irritated by what you're saying, right?
Mm,
Like this happens in the therapeutic space all the time. And if we are finding it difficult to recognize that that's telling us something about how this person is showing up, it's not telling us about our own failings. If we can then get caught up in our own stuff quite easily at this point. So I think being able to read the room requires enormous bravery because you're reading not how the room, not how you're creating this, you're reading how it's landing, right? And that's important information
mm,
because now you know, okay, if this person is like, if their non-verbals are basically saying fuck off, right? Like,
yeah.
right? Because they're in pain, they're tired, they're using medication that's probably coming with other side effects. They could be somewhere else, right? Which is true. And if they're like, this isn't for me, you're seeing loads of nonverbal communication of resistance coming up. We
Mm,
we can take a therapeutic stance there, not a personal stance, but a therapeutic one that says, okay, I notice there's a lot of resistance here. What about this has brought up that in you? Like that's an opportunity for us to get to know the other person a little bit more, and for them to let us in, and for us to let them in a little bit more, and open that therapeutic space and say, I'm not going to force anything on you. But I do think this would be really helpful, and I'm seeing that you're not into it. Like, how can we bridge this gap? Because from a therapy perspective, this has shown to be helpful, but I can
mm,
see that you as an individual are not getting it. And often it's just that we're not calibrated. They were expecting something else, you were expecting something else, you came in with an idea, they didn't match it. So I think noticing nonverbals is really, really important. Um,
mm,
and also, what does it model to that person in front of you? It models safety. What you're saying is, I'm not only listening to the words that you're saying, I am watching your body. I am invested in making sure this goes well, and I'm seeing that you're not liking what I'm delivering, and I'm here to say I'm flexible. I'm ready to work with you, not at you. Yeah?
mm.
But that's that. I know I've gone on a bit, so I'm sorry.
No, no,
I
no,
need to
no,
keep
no.
talking. I'm trying to speed up, but I just love
I
this
was just
topic
going to
so
say
much.
that, like, I'm literally listening. I'm hanging on every word because it just, to me, this just demonstrates your just huge, not only huge skill in navigating these really difficult situations, but actually your ability. And I know that you hate me singing your praises, Laura, but your ability to actually communicate this and teach others how
Yeah.
to notice and implement this in their own work So you're very humble and you will never let me say this stuff wrongly,
I'm
but
like
you are phenomenal. And I
cringing
know
on the inside.
everybody is just listening, like with, they're hanging on
Yeah.
your words. So carry on, go.
Yeah, so that's my first one. So noticing the behavior in the moment, and also I think there we also need to invest in our own well-being, right? Because when we feel resistance from the person in front of us, we might interpret that as a failure in us.
Mm,
And I really, like, you know me for years, Joe, like I am an advocate for clinician health, right? Like you as clinicians, everybody that's listening, you are amazing, right? You are doing a good job. You are doing your best. This is a really hard thing to do. You're working with another person. You're building a relationship from nothing where there is
mm,
a power exchange already happening. There's lots of things going on. It's not because you're failing or doing something wrong. It's just, this is hard and it doesn't always sync up immediately.
mm,
So I really think when we're thinking about this skill, it would be unethical and unfair for me not to say this is where us as clinicians also need psychological or therapeutic support to process these events safely, right? Because you've got to be able to do that in 20 minutes with your next patient again and again and again, and then go home
mm,
and look after yourself and feed your family and do go to the gym and go out with your mates and enjoy yourself. And the stuff that we experience in our day can sometimes make it hard for us to get the release and the relief that we need to let go of the stress and the strain of the job we do as well. So I,
100%.
I, I know that I'm running over because I'm only on point one, but like that's really, really important. The next thing we need to do when we're reading the room is listen for the learning signals that this person is saying. Are they leaning in? Like, are they asking questions? I absolutely love it when a patient says, "Why? Tell me more about that. I'm not sure."
Mm,
Or like, "That doesn't make sense to me." Because that's a learning cue. They are invested now. They're like, "Okay, you're offering something. It doesn't make sense. I want to know how to make sense of it." So looking for those little cues is really important because you're starting to see this forward momentum now. You're starting to see this syncing up.
mm,
Um, and also, asking them quite a lot, how are you feeling with this? And that brings me into the next one, being able to be flexible, when someone starts to get overwhelmed. So somebody can be really interested in the beginning, and I'm sure everyone's experienced this because I can even think of moments like last week where I totally flooded a patient and I just saw their eyebrows go up and they were like, I was like, oh, sorry, I've got carried away. Let's stop. I can see I've got carried away. I can feel it in myself because I've got excited. So,
mm,
like being able to adjust flexibly to the level of the person in front of you, um, and know that like that isn't a judgment. It's like, people can take in what they can take in, and sometimes that's more, sometimes it's less. And our job as the therapist is to be able to observe what's happening in the room, separate to our own stuff,
mm,
and flexibly respond to it, and support that therapeutic process. So
mm.
these are the things I look for. So nonverbals, learning signals, and being able to adjust flexibly.
Yeah, fantastic. Thank you. So, okay, you mentioned a story shift technique. Can you explain what this means and how clinicians can use this practically?
Right. I think that I got this a lot from Lorimer. Like Lorimer is such a great advocate for this co-creation of narratives and using narratives to change how people understand themselves in the world. So, like, if you haven't ever seen Lorimer speak, go and see him speak. And I think I remember reading, what's it called? Yarns, the book, Pain Yarns.
Yeah, painful yarns. Yeah.
Yeah, yeah, that's it. And I remember thinking, oh, that's what they're talking about. So, like painful yarns, the idea of using narrative isn't giving people a new narrative, right? So I can't use the stories in that book because they're Australian outback stories, and I live in like Amsterdam. You
Yeah.
can't start talking about rattlesnakes. No one's got that. No one understands that. But what we're trying to do is we're trying to facilitate a shift in the narrative. So the whole point of using narratives or stories therapeutically is to take people from a position of feeling powerless within their own experience to an
Mm,
empowered place, right? That's that transformational shift. How does this story that we're working on together, how can I optimize it as much as possible to to supporting someone into a more empowered agency filled space, right? And that's that link between lack of agency and chronic pain that we're wanting to work on, that we've seen in the evidence as well. So we're
mm,
looking to use the story in that way, and so that means it's very much a therapeutic decision. Yeah, so we're making therapeutic choices. We're looking and thinking about that, how we can support the person to build their story as much as possible. So, okay, and what happens now? And what do you think might happen next? Using questions that invite them to sort of build their own adventure as it comes to pain and
mm,
understanding their pain in new ways. So we might put in a snippet about let's say I'm particularly thinking about pain as a contextual thing because that's where I'm interested in. Like I might ask them about, we've got these things called nociceptors, and they might fire if there's potential damage, but that doesn't necessarily mean we always have pain with those things. So we're trying to separate this idea from, pain as a sensation to pain as a perception that's built up across different contexts. And so I might use
mm,
that in my story and model that all the time. And, remembering that when you're in that therapeutic space, it's not about you and your knowledge. It's about them and their needs. So at every moment, how does this work for you? What does this mean for you? What matters to you right now? How might you use this? How might you tell this to someone in your environment? So we're constantly giving the power back all the time. That's where I am in. That's how I think we can best use narratives underpinned by scientific research.
thank
Yeah.
you. I'm just going to skip forward now, just so I'm conscious of time.
Yeah.
By the way, if you want examples of sort of narrative stories, you will find them on the Noi Group website, I believe, in the Noi Jam section. So there are examples there of things that you can read that you can use with patients.
Yeah.
But just adapting them to the patient context or your context
Yeah.
culturally, or you can adapt them, but it will give you some ideas for those kinds of things. Um, so, Laura, we're just gonna. I love this bit where we sort of just goes like top tips from the session, which is so for clinicians who are watching and they want to really start to implement these ideas that we've talked about today. What would be your top practical tip, your top takeaway from today for somebody to implement these ideas practically?
Yeah, so I think that one of the most important things is that we start co-creating meaning and using that together. But in order to do that, you have to understand where the other person is coming from. So what I do very quickly with people very early on is try to understand, what is their understanding of pain as a starting point? What do they think is happening? How do they make sense of their world? I'm asking them to tell me their story of pain, not what's your story in general, but like what do you think is going on? How do you think you've got here? What's been part of this process? What stood out for you? What do you think pain is telling you when it's there? What do you need to do when you feel pain? What's the urge? What's the coping strategy that comes through? And one of the ways that I practice this safely is by creating a container. So the first thing that I do is I just get a big piece of paper with nothing on it, and I just write four letters, PAIN or PIJN in Dutch, so pain, pine. And I say, right, I want you to tell me everything that you think is important about this word. Like, what does it mean to you? And then we can start building up and calibrating on the meaning of that word first of all, because people are not blank slates. They've had time to think about their pain. Sometimes they've had 20 years to think about their pain. They haven't just been
Mm,
sat there waiting for some, therapist to implant a new meaning. They've been building it over time. And this is the difference between pedagogy in its where you're working with children, and andragogy, where you're working with adults. And Bart van Buchem, he has a loads of information on this, and like he's the one that taught me about this. But like adults are coming to you with a belief system, and if we want to update that, we need to first of all honor that belief system and understand it, and then we need to ask permission to undermine it in the hopes of it opening up new ways of doing things, and then move slowly into that and build in repetition. So this is my tip: is first of all calibrate on the person's understanding of their pain and give that time to build and grow. Let them have a week with that, thinking about it, do it a bit together and then let them come back after a week. You'll be amazed at just how rich the sense making process has been for individuals with pain, and why you might be hitting up against walls, because there's some very deep seated belief systems in there that may or may not be helpful.
Okay, thank you, thank you, thank
Yeah.
you, thank you.
Hmm.
We're going to wrap up now. But anybody that is interested in understanding just a little bit more about Laura's upcoming pain courses, the links are in the chat. If you want to click through, there'll be all the written stuff there on the website.
Hmm.
And if anybody is interested in doing a deeper dive with Laura, she's obviously just scratched the surface today, a tiny little section of what will be covered in the core course. And if anybody is feeling inspired by what Laura's been talking about today, Laura, can you just tell us a little bit more about your Explain Pain courses, the online one, which is a 4-week online
Hmm.
format, and
Yeah.
then the 2-day one in Dublin?
Yeah, so I mean, I obviously focus on the sort of psychological process that is taking place when we are using neuroscience education. So I'm teaching Explain Pain using stories and neuroscience blended with ACT to help clinicians learn how to flexibly use pain science with their patients, so they can move from a sort of a fearful and confused place into clarity and action. And this approach combines knowledge of psychological flexibility, so people don't just understand their pain differently, and clinicians don't just understand the process. They can actually use it and make it their own. That's the idea. And over the 4 weeks, you're going to learn, practice, and return. So you're going to do something, go away and practice it, come back and reflect on it, and then hopefully we can keep integrating this into practice. And like, I'm just going to say this as clearly as I possibly can. This is not about giving you a script on how to deliver something about pain neuroscience or telling you what pain is in the biology, right? That's your job as clinicians as well. You've to keep up to date with the research and the evidence. This is how you can best use that knowledge that you have to support people to make meaningful change, whether it's in their conceptual understanding of pain or in the way that they're managing pain. And I think that is enormously valuable and it's going to make your job easier.
Which is pretty much, yeah, what this is all about, isn't it? Helping people to be the best clinicians that they can be and to help their patients in the best way that
Right.
they possibly can. That's why we're all here.
Yeah,
That's why we
exactly.
keep coming back and doing these. And also, just to add to that, is that any of the courses that we do, the Explain Pain courses, we go way beyond the classroom. So
Hmm.
these sessions are here to support beyond the
Hmm.
course. You will have access to Laura going forward. You will have access to other NOI teachers going forward in these clinical discussions.
Hmm.
We do not just teach and then leave you to get on with it. We are here as an organisation to support you through much, much further through the process. So
Right.
thank you, Laura. Thank you for sharing your expertise with us today. And thank you, everybody, for joining live. And thank you if you're watching on replay for your interest in what we've been talking about today. We hope that you found it interesting and we hope you found it valuable. And we will be doing another one of these in a couple of weeks' time. Keep an
Yeah.
eye out for the booking link, and we hopefully will see you next time. Thanks again, and thanks for joining live. Take care, everybody, and enjoy the rest of your day, your evening, and we'll
Thanks,
see you again
everyone.
soon. Take care. Bye bye.
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 Thanks.